US, myopia is booming, but between compounding challenges, insurance headaches, and the lack of public health campaigns, the road from guidelines to the clinic isn't exactly smooth. Hi, I'm Dr. Ken Nischal, and I'll show you how the WSPOS 2025 consensus can work in American practice, covering dot lenses, atropine realities, optical lenses, and how to get families fully on board. If I have to pick one, it is the behavioral intervention. 2 hours daylight exposure, no reading in dim light, and after 30 minutes of close near work, a 5-minute break. I think that if we can all get children to do that, anything we do above that will have such a greater effect that it'll be more satisfactory for parents, patients, pediatricians, and the eye health care workers who look after these kids. You've got to look at the family history. We know that if both parents are myopic, then the child's likely to have, myopia. So you could see a child who's a pre-myope, that's anything between plus 0.75 to minus 0.5, but if both parents are -8, you know where that child's myopia is going. The second thing is you need to ask them about their lifestyle. If they're a kid who's a beta tester for FIFA Pro because they're playing inside all the time, you know that they're at risk, right? You also got to think about, is the child a really sporting child? So let's say you've got a child that's high risk and is 7 or 8 years old. I think that's important to offer firstly, behavioral interventions. And in fact, in my practice, I almost make them sign a contract. I say, look, if you're not going to do this, I'm not going to treat you. If a child was very sporty and I was really worried, let's say he was -2 already and had both parents were myopic, I would try and push them to contact lens technologies. I would see them, I would get an axial length measurement on the first visit and then again in 6 months. If they're growing by like 0.1 or more millimeters, then I would go, okay, this isn't working on its own, so we need to add a second therapy. I'd have a lower threshold to add pharmacological. But again, I would start off at 0.01 with tight behavioral interventions, see them in 6 months. If they were progressing, I'd go to the higher dose. I think axial myopia is really important. I think a manifest refraction is very important, but a cycloplegic refraction at least once a year is very important too. What is success? If I have a child who over 6 months doesn't become more myopic at all, that's a massive success. If they progress by 0.25 in the first 6 months, but then you get to the second 6 months and it's remained at 0.25, I'm happy. If at 0.25, I'm going to watch them. If they go again another 0.25, then that's not a success for me anymore. I need to get in there and do something more than I'm doing already. The MySight lens, which is the only FDA-approved optical therapy in the United States at the moment, it works. I know this sounds crazy, but one of the things I ask 10-year-olds is, how tidy is your bedroom? And they will look at their mother. If your bedroom's tidy, I know it sounds ridiculous, but it means that you've got a degree of self-discipline. Orthokeratology, you've got to make sure that the parents understand that their role of putting the lenses in and taking it out is really important. I do counsel them on microbial keratitis, but I say to them that the risk of microbial keratitis in the United States, where we are in Pennsylvania, right, is no higher than the risk that if their child was wearing a soft contact lens every day. The dot technology is really interesting. What they basically found was that there were certain polymorphisms at a genetic level. When they occurred, you ended up getting a high contrast, and that high contrast drove myopia in certain conditions. If we can reduce the amount of contrast, then that may slow the myopia progression. The 4-year Cypress trial, basically, they looked at 2 types of dot technology, 0.2 and 0.4, and they found that the 0.2 very clearly reduced myopia progression. This moment in time, dot technology is not FDA approved. The FDA gave it a status. They want to encourage them to develop that technology, raise the awareness of that technology. A clinical recommendation has to take into account the family's social circumstances and their insurance policy. You know, you have to understand what they can afford and what's affordable. So you have to talk to them and say, okay, we can go down with the atropine route. Some parents will say to me, can we just try the behavioral therapy first? And I'm going, yeah, sure, but be strict with it and let's see what happens in 6 months. Now, sometimes, not all often, but often enough for it to be important to do, I'll get a surprise and the child will not continue to be myopic because the parents have been so strict. We only have contact lens therapies in the United States, and those are expensive. What you want to try and explain to parents is, look, the child's going to be wearing glasses anyway. So let's say the normal glasses cost $100 and the contact lens costs $150. So your cost, actually, your extra cost is the $50. And I think through that conversation, they often understand. I think you have to work with the family to help figure out the goal that you want and how they can achieve that goal.